I-share ko dito.
Ayun, yes po. Tapos dapat naka-on po yung
Okay. Saan ang micro? Okay. Good morning, everyone. Morning, the one in online. Can you hear me?
Yes, Doc.
Look at the online.
Yes, Doc.
Clear?
Yes, Doc. We can hear.
Okay, so anong year kayo? Second year? Okay. Sige. Is this 2 sections or 1 section? 2. Sige. Good morning. So I'm asked to lecture on fluid and electrolytes, but this is a very long topic. So we will just focus on hypo and hypernatremia and hypo and hyperkalemia. Okay. If you have some questions on the other topics, just ask me at the end of the lecture. Okay. So we review. So definition of terms. So the body fluid, you have the extracellular fluid, which is 25 to 45% of the total body water. Total body water patient and the gender. So in general, adult would have 60% total body water, while it's about 50% for female. Then for patients, elderly, especially 70 and above, that's 50 for men and 45 for women. The newborn, their total body water can go as high interstitial. The extracellular fluid is divided into interstitial fluid and intravascular fluid. So 75% of the ECF is in interstitial and 25% is intravascular. Intracellular comprise 55 to 75% of the total body water. Then let's define particle concentration per kilogram of solution as compared to osmolarity. It is a solid particle concentration per liter of solutions. Remember, the osmolarity is stable. You change the heat, the weight will still be the same. The volume might expand when you boil something. When you boil water, it will expand. So the osmolarity will change. So mas stable yung osmolarity. Okay. So effective, when you talk about effective osmoles, that's solutes restricted in one compartment. So this is the one that would take effect on the changes of shifting of water from one compartment to another. So tonicity is the ability of extracellular fluid to make water move into or out by osmosis in a brain. No? So in effect, synonymous to effective osmosis. Okay. Ineffective osmoles is solutes particle that can freely diffuse across the cell membrane. Okay, so ineffective solutes will be like urea, since it can pass through the cell membrane. So let's just review the Starling forces that you have learned in first year. So you know the cause of filtration would be the difference between the hydrostatic and the oncotic. No? The hydrostatic pressure filtration and the absorption, no? So when the capillary static pressure overcomes the oncotic pressure, then you will have filtration, no? So you know that the hydrostatic pressure of the capillary will tend to move out the fluid out of the capillaries. Whereas in your, like in the capillary is that your blood, so the protein within the blood create osmotic pressure, then that would cause a holding of the fluid inside the capillary. So filtration is the, I think how to compute for it is the calculating net filtration rate is the KF is the capillary filtration coefficient. You multiply it by the difference between the capillary pressure minus the interstitial pressure, hydrostatic pressure. Then you also subtract it on the difference of the oncotic pressure of the capillary minus the interstitial pressure of oncotic pressure of the interstitial fluid. So for this example, like this example, to compute for that, if our hydrostatic pressure, which is in this, is capillary hydrostatic pressure is 25 minus the interstitial fluid hydrostatic pressure, which is -5 millimeter. Why is it -5 millimeter mercury? Because in the interstitium, the lymphatics are working and draining, so it will create the negative pressure. So with this, that is the capillary hydrostatic pressure of 25 minus -5. That's the value there. I think I have another slide. So that's 25 minus 5, and the capillary oncotic pressure is 25 minus the interstitial fluid oncotic pressure, which is 10. So then the coefficient, capillary filtration coefficient is 10. So 10 times the difference for this is 15. So that's 10 times 15, that's 150 ml per minute is the filtration rate of this particular anomaly. So the diffusion is movement of substance by virtue of concentration difference. So we know that the main cation extracellularly is the sodium, and for intracellular fluid, the main cation is the potassium. So the water molecule, so from if it's more concentrated dito, diba? So what will happen? It will attract the water to move to the other side. So osmosis, so the difference now. So osmosis is the movement of water across a semi-permeable membrane. So higher concentrated, na hyperosmolar na solution, you will tend to pull the water there. Whereas diffusion is movement of the solutes by concentration gradient. So sodium is both associated with volume and water. So when you see a serum sodium, that does not equate, like if you have a hyponatremia, does not equate that your total body sodium is low. So because it is also a water balance. So if you have loss of you retain sodium, but you retain more of fluid, like in congestive heart failure, in renal failure, and liver cirrhosis. You will have hyponatremia, but the total body sodium is high. So what controls the volume and water control? No? So the volume, the main hormone that is the RAS, no? The renin, angiotensin, aldosterone system. So what will it do? The decrease in delivery of sodium chloride to the macula densa stimulates the release of renin. So what does renin do? The renin will convert angiotensinogen to angiotensin. Then the angiotensin will stimulate the aldosterone. At the same time, then angiotensin 1 will be acted by the ACE to convert to angiotensin 2, which is a potent vasoconstrictor. So what does aldosterone do? It reabsorbs sodium in the distal tubules and the collecting ducts. So what will happen? The net effect is increase both the sodium and water reabsorption in the kidney. So with that, you maintain or you improve the intravascular volume of a patient. So if you already have an excess sodium, what will happen? It will just shut down. So it's the opposite, no? So there are always a negative feedback. Whereas the vasopressin or the antidiuretic hormone, it is the hypovolemia. It's a non-osmotic stimulus, no, for the ADH to be secreted in the brain, no, in the hypothalamus, the pituitary. So for a schematic diagram, so when you have dehydration, sodium deficiency, or bleeding, that will cause decreased blood volume or a decrease in effective intravascular volume. So it will cause decreased blood pressure. This will now detected by the juxtaglomerular cells in the kidneys, and it will release the renin. So what does renin do? As I mentioned, it will increase, convert the angiotensinogen to angiotensin 1. Then the ACE in the lungs will convert angiotensin 1 to angiotensin 2. So the angiotensin 2 will cause vasoconstriction of the arterioles. It can also stimulate the adrenals to release aldosterone. So aldosterone, it will absorb sodium, then this will increase the blood volume or blood pressure to improve. So this is a schematic diagram of that. How about the water control? So it is the osmolality naman ito, no? So the osmoreceptor in the hypothalamus will be detected, then that one either a increase in osmolality, so or a decrease in volume, hypovolemia, will both stimulate the hypothalamus to produce an antidiuretic hormone. So the antidiuretic hormone will act on the distal nephron to come out with aquaporin receptors. The aquaporin receptors will cause water reabsorption. So with the water reabsorption, you improve your volume and you decrease your osmolality. Okay, then if you reach the threshold, then it will shut down. Okay. So the threshold value is 280. Beyond 290, the water reabsorption is maximal. And the thirst is the response to osmolality over 290. So you will feel thirsty. So that's why usually you, in a conscious patient, that you don't ask them to be on NPO, you seldom see hypernatremia, because the thirst mechanism will always trigger when your osmolality is more than 290. So you will always look for water and drink. Unfortunately, you do see hypernatremia in patients who are post-stroke that we control. We do 10 GT feeding. So when we are not very particular in the volume, we don't watch it, so patients will end up having hypernatremia. No? So, but if the patient is, if any person would be allowed to just drink, they're conscious that they are not deprived of water, they can access water, they will always, once the osmolality goes up, thirst mechanism will be triggered, and you would really drink water. Okay. So in patients with hypovolemia, the threshold goes down. No? So that's why you would have earlier to release the vasopressin. In eubulimic, as I mentioned, it's 280. Then if you have hypervolemia, the trigger will be also higher. So this is just a schematic diagram where the vasopressin or ADH will act. No? It will act here and will insert the receptor, the aquaporin, 2 receptors. So this one will tend to reabsorb water back to the circulation. So how do you define hyponatremia? Is any serum sodium less than 135. So the severity would depend on the level. No? It's severe when it's less than 120, moderate between 120 to 129, and mild between 130 to 134 MEQ per liter. Then the onset, no? So the acute, which is developed less than 48 hours, the hyponatremia developed within less than 48 hours, and if you don't know, you cannot extract from the patient, so it probably more than 48, or we consider that as a chronic. Why is it important? Because if it's a chronic, we have to correct it slowly. Okay. So whereas if it's acute, especially if the patient is symptomatic, then you have to correct the hyponatremia a little faster. So when you see in your patient's laboratory of having hyponatremia, it's not a knee-jerk reaction that when hyponatremia you give salt. You have to know, is there a volume problem, or is there a problem in the water, or water and volume? No. So with that, you have to think: is the patient hypovolemic? So you extract history. The patient has blood loss, diarrhea, dehydration kasi nagmarathon. So you have to look at that, no? So hypovolemic hyponatremia, this is the one that is true that the sodium, body sodium is low. But at the same time, the water also is low. But the body sodium is lower than the loss of water. Okay, so that's why you still have hyponatremia. Because if you have more of water loss without sodium, what you would come out will be a hypernatremia. Then eubulimic hyponatremia, you have normal body sodium, but with a total excess of free water. Hypervolemic is both sodium and water that is high, but the water is way higher than the increase in the total body sodium. So if you look at it, what would happen if we have hyponatremia? No? So this one is the cell, the upper corner. Which way? The upper corner here is with a normal osmolality, your cells are normal. When you have decreased osmolality or a decreased you have hyponatremia, what would happen is your cells will swell. If you have hypernatremic or hyperosmolar, what would happen is your cell will shrink. No? See, the water will come out. This one, since higher water than the sodium, what would happen is this water will tend to go in the cells. So you will have swellings, and that's why you have symptoms, neurologic symptoms in patients with hyponatremia. They will start with headache. Some will have seizures if it's very severe hyponatremia because of the brain cell swelling. So mild symptoms, as I mentioned, with nausea, headache, vomiting. In severe, it could have seizure. So if you have a really severe brain swelling, because of the increased volume, it will herniate, no? So it can cause coma and death. If you have an acute symptomatic hyponatremia, this is a medical emergency. So the diagnostic approach in hyponatremia, very important. You get a history. So you get history. Is there anything that they were taking? No. So some patient would be taking vasopressin itself, no, or medications that would stimulate or would act like a antidiuretic hormone. So physical exam, then of course you, aside in the history, you inquire for any cause for decreased volume, like dehydration, so diarrhea, vomiting, blood loss. So you would have to ask for that history. So for physical exam, you check for volume status. So signs of dehydration, signs of volume overload, no? So those are the things that you would have to look for. And for laboratory exam, you can measure osmolality or the computed osmolality, then BUN and creatinine. So if the BUN, the creatinine, usually the ratio is 1:10 to 1:15. So if your crea is 1, usually the BUN is between 10 to 15. So if you have a patient with a crea of 1.5 and a BUN of 40, so that's more than 20, you will think of this patient might probably dehydrated. So, or is there ongoing GI bleed that reabsorbs, that produce urea, that it's being reabsorbed in the intestine. So those are the possible causes. You have to check for blood sugar because there's what we call a pseudo-hyponatremia. Pseudo-hyponatremia is because it would move, it's not a hyponatremia, but it's measured. So if you have hyperglycemia, like for example, the blood sugar is 300, then you have a sodium that is 130. So there's actually a formula to compute for correction of sodium based on hyperglycemia. Sorry, I think I did not put that. So it is the measured sugar, glucose. So for example, it's 300 minus the upper limit of normal, which is 100. So 300 minus 100, that's equals to 200. So the 200, so you divide it by 100. Then multiply it by 1.6. So whatever the finding, so 1.6 times 2, that's 3.2. So you add that to your measured sodium. So your corrected sodium, it's 133. Okay? So the rules is for every 100 above 100, you add 1.6. You follow? Okay, so that's the formula for correcting sodium, measured sodium based on hyperglycemia. Okay, so that's the one. For BUN, there's also a correction. The BUN is the upper normal value is 25, and the molecular weight is 28. So that's BUN for every 28 above 25, you add 3.3. So the computation for that is the BUN measured. For example, the BUN is 100. You minus 25 because that's the upper limit of normal. So 100 minus 25 is 75. The 75, you divide that with 28. The 28, so the product, the quotient, I mean. So 75 minus divided by 28, the quotient, which is 2 point something, times 3.3. So the result, the product for that, you add it to your measured sodium. Okay, you follow? Okay, so that's why we need to also measure the sugar in patients who have hyponatremia. We measured BUN to check for the kidney function. At the same time, if there is a high BUN, then you have to correct also the sodium based on the high BUN. No? So serum uric acid and imaging study if you suspect SIADH. SIADH is inappropriate secretions of ADH. So this is common. We see it in patients with lung problem, with CNS problem. So if you're suspecting of SIADH, you want to find out what's the possible cause. So you need an imaging studies. So the diagnostic approach to hyponatremia. So first is you always assess the volume status. So in some so hypovolemia, euvolemia, hypervolemia. So this one, there's signs of dehydrations. So you have low of total, there's a decrease of total body water, but more decrease of total body sodium. Whereas in euvolemia, you have a normal body sodium, you have a higher total body water, but no signs of edema yet. The hypervolemic is you would see signs of volume overload. So you would have higher total body water and high body sodium. So what would differentiate the difference is you look for urinary sodium. So urinary sodium is effective when you have not given any diuretic. Because when you give a diuretic, it will block the absorption of sodium. So regardless what is the cause, your urinary sodium will be high. So you measure that when there is the patient had not received sodium diuretic, or you wait until the effect of the diuretic disappear, no? So like furosemide, the effect is 6 hours. Morning again. Can you hear me now?
Yes, no.
Okay, sige. Okay, so for where were we? Urinary sodium. So for hypovolemic hyponatremia, so if you have less than 20 urinary sodium, 20 MEq per liter, that would mean more of extra renal losses, because if you have an intact kidneys, it will try to conserve sodium. That's the reason why you have a low sodium in the urine. Okay, for eubulimic, usually the urine sodium is about 20 MEq per liter. So usually it could either be a glucocorticoid deficiency, hypothyroidism, stress, medications that are taken by the patients that can cause the syndrome of inappropriate secretions of antidiuretic hormone, or SIADH. For hypervolemic, if it's more than 20, usually you see that in acute or in chronic kidney renal failure, and in less than 20, you see that in cirrhosis, congestive heart failure, and nephrotic syndrome. So with this, you would always, if the patients, you have to address the volume first, no? So if hypovolemic, you restore the patient's, correct the hypovolemia. If it is hypervolemic, you also correct it by giving diuretic and restricting fluid. Eubulimic, usually, if the patient is asymptomatic, we just restrict the fluid with the goal of, usually we restrict it less than a liter or less than 1.2. So depending on the urine output of the patient. So urinary sodium would distinguish a renal problem from a non-renal problem. So the SIADH, the intake of free water at serum osmolality is lower than the usual threshold for thirst. So what happened? Osmotic threshold and osmotic sensation of the thirst are shifted downward. Volume expanded due to vasopressin-induced water and sodium chloride retention. So when there's a serum uric acid is low, the kidney senses that as a volume expansion. So it also will excrete further uric acid. That's why you will have serum uric acid that is low in SIADH. Common causes, as I mentioned a while ago, would be pulmonary diseases, malignancy, medications, especially like the antidepressant is a very common cause of hyponatremia. So if you're giving patients antidepressant, you would have to monitor, especially if it's elderly. No? So this is the same. No? So despite the maximal urinary concentration, vasopressin level continues to rise. Supposed to be when it goes up, this will shut down. In SIADH, it continued to secrete. That's why it's called as syndrome of inappropriate secretion of ADH. So the causes. So these are the common causes for malignancy, usually the lung, GI, and GUT. No? Pulmonary diseases, so ordinary pneumonia can trigger it. So PTB, viral pneumonia, fungal, also with any form of respiratory failure. For CNS disorder, so like encephalitis, meningitis can cause that. No? You have brain abscess, so it can cause SIADH. So medications, so it can, chlorpropamide is one, tricyclic antidepressant, clopidogrel, this is for hypertriglyceridemia, carbamazepine, vincristine, which is a chemotherapy agent, narcotics, antipsychotic drugs, cyclophosphamide, and immunosuppressive medication, even an NSAID, no? And the vasopressin analog, like desmopressin, and that's why pregnant women postpartum are predisposed to develop hyponatremia because it will release oxytocin. Then oxytocin would act like an antidiuretic hormone. Okay, so that one. So there's hereditary genetic mutation, no? Pwede. Idiopathic, transient, endurance exercise can also do that. So there's a lot of causes of SIADH. So principles of treatment in hyponatremia. I would want you to understand the principles, then the practice lang ng correction will follow later. No? So the presence of hyponatremia, you would have to detect this, the guide would be, you have to know the severity. Of course, if it's severe hyponatremia, you have to treat it right away, no? But the goal would be different. So for chronic hyponatremia, your goal would be no more than 8 to 10 MEQ of correction. So if the patient's sodium was 110, you don't aim it to correct it to 138 or 140. So the first 24 hours, your just goal is to get it to about 8 to 10, no? In 24 hours. So from even if it's 110, that's okay. You have it at 115, 118, then gradually correct. So the problem with correction of sodium is different patient, unpredictable, even if you compute. So that's why you have to closely monitor the sodium. Sometimes we need to get it every 4 hours. And unfortunately, it's cost a lot because the sodium itself would range between 700 to 900 maybe pesos in the laboratory. So if you get it every 4 hours, medyo mahal. So maximum of 18 MEQ or millimoles within 48 hours. So the is you correct, but correct it slowly. The response to treatment, so you need to measure. So of course, if it's the eubulimic hyponatremia or if it's a hypervolemic, you correct the underlying cause. So if there's if SIADH and because of infection, treat the infection while correcting. So for SIADH, most of the time, it's more of water restriction is the treatment. So potassium replacement is needed in patients who also have hypokalemia. So you correct it simultaneously. So what are the isotonic solutions? So the NSS, the normal saline, the lactated ringers, the ringer solution, and even the D5 containing. This is in terms of osmolarity. No? Then hypotonic is siempre the half saline, which is 77. 0.3 sodium chloride is 51 MEQ sodium, 0.2 and 2.5% dextrose. Hypertonic, you have the 3% sodium chloride, a 5%, 3% sodium chloride, or 5% sodium chloride and a D5 water. Then D5 water, D5 dextrose containing water like the D10, no, the 10% dextrose could be considered as hypertonic. So the IV fluid that is common, no? So D5 water, there's no electrolytes, but there's glucose, and the osmolality of that would be osmolarity. That's Literman. Is 278. So it's almost isotonic, diba? The D5.45, so it is half saline, so it's 77 sodium, 77 chloride, but you give dextrose, which is 5%, so the osmolarity becomes high. So it's hypertonic na siya. D5NSS, so 154 sodium, 154 chloride. For ringer solution, that's a 130 sodium chloride of 109 and potassium of 4, calcium of 3. Lactated ringers, same thing, 103. The ringer solution is 147 sodium. But what we have here is the D5 water. D5.45 is now available in the country. If it's not available, it can be mixed by the pharmacies. The half saline, they would remove the 500 cc and infuse it with triple sterile distilled water. Then it becomes a half 0.45. If you want it as a D5 water, then you put a 500 of D5 water. We have the lactated ringers, both the plain LR and a D5 LR. Plasma light or an NR, if you look at it, it's very close to, that's why it's called plasma. It's close to the blood, not to the plasma. Okay, so 0.45, that's 77 sodium, 77 chloride. So same thing. 3%. The pharmacists can also formulate some institution, but there's already a commercially available 3%, the Totilac. So mannitol is also a hypertonic solution. So be familiar with the IV set. The IV set, if you look at it, there's a metal, parang needle. That's what we call as micro set. The macro is just the plastic. So what's the difference? The fluid delivery, if you use a macro set pala, it's the 1 drop of that is equivalent to 4 cc per hour. Okay. So whereas the micro drip, it's 1 cc per hour. Okay. So when you add, you order a 10 drops using a macro set, that's actually delivering 40 cc per hour. Okay. So if you ordered the GTT is drops, no macro. So 30 drops per actually 30 drops per minute, sorry. 30 drops per minute is equivalent to 120 cc. So that's 30 times 4 is 120 cc per minute. So, sorry, correct this as 30 drops per minute. So, if it's micro drip per minute is equivalent to 30 cc per hour. Okay, so when you give it a 30 cc, you want to compute how much are you giving in a day. So 30 cc times 24. Okay. So 10 drops, when you give the 10 drops, sorry, this is 10 drops per minute. That's 1 liter per day. 20 drops per minute, that's 2 liters per day. So when you have severe symptoms, so like coma, palpitation, seizures, respiratory distress, and vomiting, this is you're justified to give a hypertonic solution, no? Together if correcting, but and also fluid restriction if it's not a hypovolemic, if it's a eubulimic, or the problem, the challenge is when it is hypervolemic. So usually when you give a severe symptoms, generally it looks like the patient is eubulimic. So the treatment, first line of treatment is supposed to be fluid restriction. But if you have a severe hyponatremia or there's already symptoms, CNS symptoms, then you are justified to give a hypertonic 3% sodium chloride. For moderate symptoms, for hypovolemic natremia, so number 1 is you replete, no? So you replete, you correct the volume, so you can give an isotonic solution on oral sodium replacement. For eubulimic, you can give baptans or limited hypertonic sodium chloride, then followed by fluid restriction. For hypervolemic, you have to give baptans followed by fluid restrictions. For minimal symptoms or no symptoms at all, or a mild hyponatremia, what you can do is just fluid restriction, but consider baptans for if it's needed. So if the patient's unable to do fluid restriction, then you can give baptans also. Very low sodium which would mean when your sodium is already 125, even if there's no symptoms, you have to watch out, no, because the patient is at risk to develop symptomatic hyponatremia. So you need to correct that sodium to a safer. So what is safer? Bring it up to 130. So that's safer now. Kasama, you bring it up to 120, 130. So especially if the patients need an emergency surgery, then you need to correct that sodium. For ICU hospital discharge, you also correct that sodium before you discharge the patient to a regular room. Patients who have unstable gait, you have to correct that first because the hyponatremia could contribute. So what are baptans? No, baptans would act like in the aquaporin. So inhibits the aquaporin 2 receptor and prevents water reabsorption. So this one, when you use baptan, the patient will also diurese, but purely water, not electrolytes. Unlike diuretics, your diuretics, like loop diuretic, where will it act? In the loop, diba? It blocks the sodium, potassium, 2 chloride transport. So it blocks the reabsorption of sodium. So it comes with it drags water. That's why you urinate. But in baptans, it will block the aquaporin 2. So it will only block the reabsorption of water. So the diuresis is really pure free water. So with that, when you remove free water, you correct the hyponatremia. So it's an aquarel. So this is good to be used in SIADH, especially the symptomatic ones, and of course for congestive heart failure. So what is commercially available, and it's available in the country, is the tolbaptan. Unfortunately, the price is very prohibitive. When it started, it's about 1,000 plus per tablet. So now I think with the discount goes to about 800 to 900. It's quite expensive for it. And you take it once a day. Some we give it every other day, but that's the price. I mean, not all can afford it. I mean, for acute treatment, yes. But for like congestive heart failure that they would need it regularly, we cannot give it to all patients because of financial constraint. So next problem would be hypernatremia, which is the opposite, no? So it's sodium above 145. This is less common, as I mentioned, because of the ADH secretions and the thirst mechanism natin. So, but if it happened, it is a high mortality rate of 40 to 60%. The combined water and electrolyte deficit with losses of water exceeding the losses of sodium. State of increased insensible water loss. So like in fever, exercise, burns, in patients with mechanical ventilation. So this is very common, no? Sometimes the resident forget that the patient is already febrile because of pneumonia, then the patient is in ventilator, then they only compute for the replacement, the urine and the GI loss. They forget about insensible loss from fever, which for every 1 degree higher, that's approximately a 500 ml per 24 hours. Ventilation, you have mechanically ventilated, you can lose as high as 1 liter per day. So if the patient is febrile, highly febrile, so they can easily lose water of 2 liters. Then you restrict, you only give, the patient is putting out 2 liters of urine, have 1 or 2 BM a day, so they will just give 2.5 liters of fluid. The next thing you know, after 2-3 days, the patient is hypernatremia. Because patients rely on us, because the patient is on the NGT, the patient is intubated, cannot complain that he's thirsty. So that one. So most of the hypernatremia, as we always joke in the hospital, is iatrogenic. So you tend to forget, you focus on something else, especially the patient is septic, you tend to forget that there are other fluid loss that you did not compute. Because INO, what is listed is the IV fluid, the NGT feeding, then for the loss is the urine and the stool. If the patients have NGT drain or vomiting, the vomitus, but never in the INO, the insensible loss. So it's always the insensible loss. Okay? So ito yung the anti-hereditary. So our vasopressin, no? So where it acts. Then this one, as I mentioned, we mentioned that, diba? That at 280, the vasopressin threshold, because of osmotic, and also when you have also increasing osmolality, you would also trigger your thirst mechanism. And the osmotic of thirst is 290. So this is just the schematic diagram. If you have a hypotonic, what would happen? You would have swelling of the cells. Isotonic, normal size. When you have hypertonic, so I have hypernatremia, you will have shrinkage of the cells. No? So causes of hypernatremia, brain, affecting areas of production and secretion of ABP. So also metastatic tumors, insensible water loss that is not measured, osmotic diarrhea. So osmotic diarrhea, more loss, water loss than electrolyte loss. Osmotic diuresis, more water loss, like when you give mannitol, when the patient is hyperglycemic, you have hyperglycemia. And when patients who have enlarged prostate, then it is removed. So they will have a post-obstructive diuresis, or if the patient has stone and it's removed. So the post-obstructive diuresis, since the tubules are, and also it cannot conserve, so it will just lose water and everything. So you can develop electrolyte imbalance, no? Nephrogenic DI, diabetic. So there's a resistance, a renal resistance to vasopressin. So what are the clinical features of hypernatremia? So the increased osmolality of ECF leading to efflux of intracellular water, causing cellular shrinkage. So the common symptoms will be neurologic. The sudden shrinkage of leads to parenchymal and subarachnoid hemorrhage, commonly encountered in pediatric patients. Chronic hypernatremia are at risk of developing cerebral edema and seizure during rapid rehydration. So you also have to slowly correct. Because of the blood-brain barrier, hindi siya equal. Correcting there, so you would end up having hyponat naman. So diagnostic approach, you get the history, you ask if the patient always thirsty, there's polyuria, there's diarrhea, and how much volume. Then examination, you look at the neurologic status. So CNS examination is very important. You also assess the fluid status. You look for signs of dehydration. Then for laboratory, you both get the serum and urine osmolality, serum and urine electrolytes, and the response to desmopressin. So for approach, we look at also the volume. If it's increased, administration of hypertonic and sodium chloride. No? If it's not increased, minimum volume, maximal concentration. So what would happen is you ask if it's not maximal volume or of a maximally concentrated urine, you look at the urine osmolality. It's more than 750, then yes, that's usually diuretic or osmotic diuresis. If it's no, renal response to desmopressin, you look. If it's you look at the urine osmolarity, if it's increased or unchanged. If it's increased, that's central DI. If it does not change, it means it's a nephrogenic DI because it does not respond to vasopressin. So if it's concentrated, then most likely it's a loss. It's most likely GI or insensible loss, water loss. So there's such thing as you have a patient, that's a very common also, that the patient is for hyponatremia. It's very common for patients like with stones. So some patients with stones, you usually restrict the salt, but sometimes when they have a chronic stones, they end up having salt losing nephropathy. They lose salt, and you restrict your sodium. So this patient would have true hyponatremia. So be careful, and patients with kidney problem, you really have to monitor and check because you can push them both ways. Volume overload, hyponatremia, hypernatremia, because our kidney is the one controlling, correcting any small difference. This is why even if you drink a lot of water, if you have a normal kidney, nothing will happen because your antidiuretic hormone will set in, vasopressin, it will shut down. So as long as you have a normal kidneys, most of the time you would not see the electrolyte imbalance. No? Given enough time, it will correct. So for management of hypernatremia, you have to estimate the water, total body water. So this is what I mentioned, 50% for adult women and 60%. So if the patient is 70 kilos, so 50%, 70 times 0.5, that's, diba? So that's 35 liters of total body water. And if it's 60, that's 42 liters. No? So calculate free water deficit. So what you do is the measured sodium minus 140, which is the normal, times the total body water. So you administer the deficit over 48 to 72 hours. So 2 to 3 days without decrease in plasma sodium by more than 10. So you just correct it by more or less 8 to 10 millimoles per day. Okay, that's why you would have to correct it slowly, no? When you have ongoing water loss, you have to add that, no? So here, the V here is the volume, urinary volume. U, sodium, urinary potassium, and the plasma sodium. Then insensible loss is usually approximately 10 ml per kilo per day. The loss, patient if it's febrile, no? Add component to the different water deficit. So this is the water deficit, then this is the ongoing loss and insensible loss. So for your correction, you have to add your deficit plus your ongoing water loss and the insensible loss. Then that will be your target fluid for the day. This is an example. So 50 kilo patients with 150 sodium. So your water deficit is 1.78 liters. Then the urine is 1.5. Then your sodium is 50, potassium is 30. So ongoing water loss is 0.94. Then insensible loss is, as I mentioned, 10 ml per kilo. So 10 times 50, that's 500 ml or 0.5 liters. So your that you have to give is 3.2 liters per day. So cause should be withdrawn or corrected. So if hyperglycemia, hypercalcemia, hypokalemia should be corrected. Slow correction, no more than 10 millimoles per liter per day. I mean, provide free water if it can be tolerated. Usually we give it by mouth or NGT. Intravenous, we give D5 water or a hypotonic saline, the 0.3 or the half saline. So next would be potassium balance. I always emphasize, you know that potassium is an intracellular cation ion, no? But the serum potassium is a true reflection of your total potassium, body potassium, as compared to your sodium, no? So when you have a hypo K, it is true that the patient's total potassium is low. If your hyper K, it's true that your total potassium is high. So this is the usual, no? Cellular store is about 3,300 MEQ of potassium. Majority is in the muscles. Then there's 250 in the red cells, the hepatocytes, and the bone. The renal excretion is only about 90 to 95 MEQ per day, about 1 to 1.5 MEQ per kilo. GI excretion is 5 to 10, normal. But if you have diarrhea, then that's another problem, no? So extracellular fluid, it's about 65 MEQ lang. So your intake is approximately 100 MEQ per day. So where does it ano? So in the proximal tubules, so it is reabsorbed, no? And in the distal, the principal cells where the sodium and potassium also be transported, no? It's in the principal cells, and in the intercalated, it is an exchange between the hydrogen and potassium. In the principal cells of the distal tubules and collecting duct, it is the sodium is in exchange with potassium. The entire kidneys it will always, if there's a cation that goes out of the cell, there's a cation that will go in. So that's why there's an exchange all the time. To maintain the electrical gradient of the body, no, of the cells. So sodium must go inside to create a negative potential in the tubular lumen and drives potassium. The renin-aldosterone system, so in the collecting duct, when this is acted by in the principal cells is acted by aldosterone. So when you reabsorb sodium, you secrete potassium. That's why when you have hyperaldosteronism, the secondary hypertension, what you would see is a patient who is hypertensive, who is hypokalemic because of the aldosterone, the high aldosterone, it absorbs sodium, it will secrete potassium. So you will have potassium losing. So you will always have a hypokalemia, hypertensive patient in patients with hyperaldosteronism. So factors that will affect distribution of potassium between intracellular. So what would happen? That's why this is used for treatment also for hyperkalemia. So effect on potassium, insulin, it will enhance cellular uptake. So if you have hyperkalemia, when you give insulin, it will shift. It's on, you do not lose the potassium, but it will just shift intracellularly. Catecholamines, so beta agonists and everything. That's why we nebulize the patient, because it will also enhance cellular uptake. Acidosis, it will impair cellular uptake. So it will stay in the plasma. So you will end up in acidosis, you will end up having hyperkalemia. Alkalosis, it will enhance. So it will cause hypokalemia. External potassium balance. So it depends on how much, no? Cell damage with impaired cell uptake. Then hyperosmolarity, it will also enhance cell efflux going to the cells, no? Chronic effect on ATP pump density. So the thyroid, it will enhance. That's why if you have hyperthyroidism, so when patients presented with hypokalemia, one of the things that we have to rule out is a hyperthyroidism. Okay, so the adrenal steroid, so you will have also enhanced. So when you have chronic intake of steroids, like patients who have GN that you're giving prednisone or methylprednisolone, you would see patients with hypokalemia because of the enhanced uptake to the cells, no? Exercise or training, then growth, diabetes, potassium, so they will impair the effect of the ATP pump. So what is the kidney's role in potassium balance? It reabsorbs potassium in cases with hypokalemia. It excretes excess potassium in cases of hyperkalemia. So a hypokalemic, defined as less than 3.5 millimoles per liter. It occurs in 20% of hospitalized patients and associated with tenfold increase in mortality due to adverse effect in the cardiac rhythm, in the blood pressure, and the cardiovascular morbidity. The causes of hyperkalemia is either redistribution, this is hypokalemia. Redistribution, renal loss, or non-renal loss. So redistribution, especially if the patient is asthmatic, keep on puffing beta agonists because he's having asthma attack. That's why some patient would die because of hypokalemia. Okay, So that's redistribution. Renal loss. So in patients with renal tubular acidosis, the RTA, they will have loss of potassium. So non-renal loss, so GI, diarrhea. No? So you will end up having hypokalemia. Hypomagnesemia will also lead to hypokalemia. So if you noted that the patients came in because of diarrhea, you correct it na, no more diarrhea, but the patient persistently having hypokalemia, you check if there is hypomagnesemia. You have to correct the hypomagnesemia before you finally can correct the hypokalemia of this patient. Okay, so those are the some. So clinical features, prominent effect is always in the cardiac and skeletal muscles. So there's weakness, muscle weakness. So patient usually with the hypokalemia, patient comes in because they cannot move, especially the proximal muscles. So it can cause arrhythmia, especially in patients who are on digoxin. Increased toxicity of digoxin. ECG changes would be low T wave, ST depression, QT, prolongation of the QT interval. Renal effect, you will have sodium chloride or bicarbonate retention. You have polyuria, phosphaturia, hyposcytaturia, activation of aminogenesis. So just a clue, no? If you have read about, I think you already discussing the renal tubular acidosis. The reason why the RTA, especially the type 1, will have stone formation. One of the causes is because of the hypokalemia can cause hyposcytaturia. It means the citrate, and citrate is the main inhibitor for crystallization and aggregation of crystals in the kidneys. Okay, so that's one of the reasons. So a hypokalemia, chronically hypokalemic, can cause kidney failure. Okay, so if it's not corrected, we do see this in patients for RTA that is not corrected, end up having end-stage renal disease. Okay, this is a busy slide which I cannot even see. So what is important is you treat, the first is emergency. Are the kidneys causing the hypokalemia? So if it is, sorry. So if it's very low, you have to correct. Then if you have to correct, if you give beyond 10 MEQ per, if you plan to give 10 or above MEQ per hour, you have to correct this in the ICU, because the rapid, then you have to give it by infusion pump, and sometimes you need to give it by central line or peripheral, but you have to make sure that it's intact because it can burn, no? It can cause injury. So usually the patient is under cardiac monitor because it can cause arrhythmia, especially if you also give it fast. You end up just like giving a patient a lethal injection, no? So you have to correct. If it's peripheral and it's in main line, you cannot incorporate potassium more than 30 MEQ per liter. So if it's the cause is the kidney, then what you will have to check there, no? So Can you still see it? Right. So you check for urine potassium, no? So if the potassium is less than 15 millimoles per day, so most likely that is an extrarenal. If it's beyond more than 15, because if the potassium, the principle of that is because if the kidney is intact, if you have hypokalemia, it will try to conserve potassium. So sometimes you can just see 2, 3 MEQ. If despite of hypokalemia, you have high potassium in the urine, you can automatically think that it is the kidney is the cause of the hypoK. No? So that's the reason why urinary potassium should be tested. No? So if you cannot get a clue from your history and PE, then you can differentiate the extrarenal and renal by getting a urinary potassium. So if you have renal loss, you will have to compute the TTKG. So you don't have to know that. You just have to be familiar that there's such thing as TTKG. It's a complicated computation without it. So if it's the TTKG is 4, more than 4, then you would think of distal potassium secretion. So if it is less than, you would it's a decreased tubular flow. So you would see that in osmotic diuresis. So if the potassium is the one that is I don't know more than 4, that you would have to check the blood pressure. The blood pressure is high, you would think of hyperaldosteronism. So if it's high aldosterone, then you think of you can think of you can get the renin. If it is high, then you would have to think of renal artery stenosis and malignant hypertension. If it's low, you would think of primary aldosteronism. So when the aldosterone is low, you check for the cortisol level. So if it's high, you will think, if it's a Cushing syndrome, you actually can see it by PE, no? Cushingoid na pasyente. But the cortisol there, it would be important for the renal syndromes and all those causing hypokalemia, no? And that's not common to us. The licorice, they keep on eating the licorice. It can cause hypokalemia. So in patients with normal BP, you check now the acid, the ABG. If it is the acid-base status, so if it is acidosis, then you would think of the RTA. So you have hypokalemia. Usually, we tell you that in acidosis, you will shift your potassium out of the cell. But in renal tubular acidosis, you would have hypokalemia. Okay? So, so when you have metabolic alkalosis, this time you check for urine chloride. So urine chloride, if it's less than 10, you will think of GI, vomiting, diarrhea. Whereas if you have high urinary chloride, then you will think of the patient has loop diuretic renal problem, thiazide. And if you look at that, the loop diuretic and the Bartter syndrome is a functional problem, diba? But the effect, the electrolyte problem nila is the same as the effect of loop. And the Gittelman's is the same effect as of the thiazide, because the problem in the Gittelman's is in the distal tubules. Then the thiazide will block the sodium potassium co-transport in the distal tubules. Okay, So where's the problem of Gitelman's? So that's the complicated algorithm for hypokalemia. So how to manage? So if life-threatening, you treat first before you investigate. Because irregardless what is the cause, if it's life-threatening, masyado mababa, the patient could barely move, barely breathe, you have to correct. Then just try to find out what is the cause later on. So you investigate if there's a transcellular shift. So those are the urine potassium. So this is the highlight. So TTKG, aldosterone, and ABG, you should find that out, as I mentioned. If urine potassium is low, so the kidney is working, so it's not the cause. If ABG, so you also prevent life-threatening chronic consequence. So urgent but cautious potassium replacement in redistributive hypokalemia, because once you corrected the redistributive, then you give aggressive ka na nagbigay, what would happen? You will induce hyperkalemia naman, no? The opposite. So oral replacement in hypokalemia, if the patient can tolerate the gastrointestinal, we always use the GI, no? So it's oral replacement rather than the IV. We only give it in life-threatening cases. So peripheral dose, as I mentioned, 20 to 40, average maximum 30, no? Administration via central line, you need to require ECG monitoring. High concentration can cause phlebitis, and it's painful. The patients will always complain. It's burning. So these are food that is high in potassium. So nuts, dried fruits, the green leafy, and for the fruits, banana, cantaloupe, mangoes, oranges. So citrus fruit are high. Lanzones is high. So the meat would also have high potassium. So how about the opposite, the hyperkalemia? So define when the potassium is 5.5 millimoles per liter. Occurs in 10% of hospitalized patients and associated with increased mortality in 1% who experience severe hyper-K. Similar to hypo-K, causes include redistribution, reduced tissue uptake, and decreased renal excretion. So redistribution would be acidosis, hypoosmolality, beta-2 adrenergic antagonists, so the beta blockers, the antihypertensive, no? Succinylcholine, rapid tumor lysis, so destructions of cells, so hemolysis or tumor lysis when you're treating myeloproliferative diseases. Then can cause tumor lysis. So the release of potassium intracellularly can cause hyperkalemia. Inadequate excretion when you use ACE, ARBs, renin inhibitors, and aldosterone antagonist medications. So decreased delivery in congestive heart failure and in volume depletion. So decreased excretion in chronic kidney disease and acute kidney injury, and primary adrenal insufficiency. So you don't have aldosterone, you retain also your potassium. So medical emergency is mainly due to the effect of the heart. So it can cause cardiac arrhythmia, it can cause sinus bradycardia, sinus arrest, slow idioventricular rhythm, it can cause beta, VFib, and asystole. Sorry, this is asystole. Has negative effects on the kidney, ability to excrete an acid load. So it will contribute to further metabolic acidosis. So the ECG changes approximate At 5.5 to 6.5, what you can see is a tall peak T wave with a narrow base. So you see that in the chest leads, no? The V1 to V6. When the potassium is 6.5 to 8, you will have peak T wave. You start to have prolonged PR interval. You also have decreased amplitude of P, and you start have a widening QRS. Pag more than 8, you will have low absence of P wave. You will already see all the arrhythmia, the ventricular arrhythmia. So it can cause a systole and patient will go into arrest. So that's why this one. So emergency therapy, if it's needed, too long. Yep. I'll move the slide. Okay. So if it needs emergency therapy, if you said yes, yeah, potassium niya, hyperkalemia, di ba? If the potassium is more than 6, you need an emergency therapy. Okay. So what is the emergency therapy? You have to stabilize because the bad effect is in the heart. So you have to stabilize the myocardium. So that's why the first treatment will be to give a calcium gluconate. No? If it is pseudohyponatremia, hyperkalemia, then you don't have to treat. If it's not, then you have to get a history. So if it's not pseudohyponatremia, it's not more than 6, then you have time to find out what is the cause. No? So there, you get history and PE and laboratory. So if there's an evidence of increased potassium load, so you treat it accordingly. If evidence of transcellular shift, so you correct why there's a transcellular shift. No? So if it's there's no evidence of transcellular shift, there's no evidence of increased potassium load. Now you find out if it is a decreased potassium excretion, so with less than 40 millimoles per day. So you get an urine electrolytes, you compute for your TTKG. If it's less than 5, so there's a reduced distal potassium secretion. And if your GFR is more than 20 ml per minute, you can get the mineral corticoid. Then if you give mineral corticoid, if the TKG is less than 8, it means there's a tubular resistance. These are the causes. The patient may have been taking diuretics and medications that would affect the tubular secretion, or other causes like tubulointerstitial diseases, urinary tract obstruction, and the rest of the diseases. No, if the TKG increases after giving mineralocorticoid, then you check for the aldosterone. If there's a low aldosterone, you get for renin. If there's high in renin, then this is due to primary adrenal insufficiency, isolated aldosterone deficiency. You're giving patients low molecular weight heparin. Patient is on ACE or ARB. If it's the renin is low, then probably acute GN, tubulointerstitial disease, and cells. So how do you manage the hyperkalemia. So if there's an immediate emergency, treat before you investigate. So the cutoff, if there is ECG changes, or even if no ECG changes, it's 6 and above, then you have to treat. So that's what I was mentioning, no? So dun sa, no? So investigate the cause due to transcellular shift. You get urine electrolytes. If sodium is low, so there is a decrease in distal delivery. You can get TTKG. So if it's more than 8, you investigate on renin and aldosterone. If it's less than, it is resistance to potassium secretions. So when you have hyper K, you admit in the hospital to do continuous cardiac monitoring and immediate treatment. So you decrease the excitability of the myocardium by giving calcium gluconate. Caution is when patients also at the same time have hypercalcemia. So rapid reduction of plasma potassium concentration by redistribution muna, no? Because the actual removal will take time. So whereas the redistribution, so shifting it through intracellularly, is an immediate effect. So you can give insulin and nebulization with salbutamol. Albuterol is not available in the Philippines. The counter of albuterol is salbutamol. So you give insulin and nebulization so that it's immediate action, but it's transient. Okay, it's just shifting. So intravenous bicarbonate has no role in the treatment of hyperkalemia unless the patient is not acidotic. You give it will not have much effect. No? Removal of potassium. So what is removal of potassium? You can give it by exchange resins, the calcium polystyrene or the sodium polystyrene. The dose is about 15 grams every 4 hours, but caution on intestinal necrosis. Then you can give diuretic because it will, when you block the sodium potassium, so it will diurese. So either you give a loop diuretic. But the most effective would be a hemodialysis. It's fast and no. So, but it takes time to prepare for the access and everything. So you have to give first the emergency medications. So the calcium gluconate, then the insulin. So you give D50 with insulin if you think the glucose is low. If the patient is diabetic, just give insulin and monitor the sugar. So that's the duration of the different effects. So dialysis. So usually after the first hour, that's the time you were able to see a significant removal of the potassium. Insulin, in less than, it's just minutes, it starts to go down. No? But it's slow. Then bicarbonate, barely, especially if there's no acidosis. Okay, I think that's the last slides. Is there any other questions? And I know this is a long topic. And actually, I just got the 4 important, the rest of the electrolytes. Then I think the one is important also that you would want to look into is be familiar with the different electrolyte content of the different body fluids, because when you treat the fluid and electrolyte problem, when you have an ongoing problem, then you need to know where your ongoing loss. Okay, so when you are vomiting, what electrolytes do you lose in vomiting. You know, it's mainly hydrogen, but it's acid man, so hydrogen chloride. So that's about 90 to 100. Then the sodium, relatively, it's a hypotonic, so it's about 30 to 50. So different books have now, but range it in that. If you have ileostomy tube, so it is in the small intestine. So you have to think, once it's in the small intestine, the fluid is still isotonic, relatively isotonic. So you would have to think that the sodium is similar, almost similar to plasma. Okay. Then so that's why if you have a secretory type of diarrhea like cholera, you are losing isotonic fluid. If you have a diarrhea like amoebiasis, it's usually a hypotonic. Usually you lose bicarb potassium. Sodium, it's about mga ano lang yan, mga 50. No? So those things. So if you have pancreatitis, tapos or you have you have surgery in the biliary tract, then you put a tube. So the tube there, you're losing an isotonic, almost an isotonic solution. So when you plan you plan your fluid management, you have to think about that. How much loss, if you have all the tubes, especially in critical patients, you have all the tubes, you have to find out where is it coming from. So if the NGT it's draining, so you know that it's in the stomach, you know that you're losing a lot of chloride, you're losing a lot of hydrogen, so you're putting the patient at risk of metabolic alkalosis. When you have diarrhea, your risk of putting patients of metabolic acidosis because you're losing potassium, you're losing bicarb there. So that's why you have to be familiar with the different body fluids also, aside from the IV fluids. So when you become senior clerks, so when you look at the patients, you look at the IV fluids, then you try to learn and remember what are the different electrolytes and the different IV fluids. Okay? Any questions? Clarifications? Or you get more confused? I hope I give some clarification on the other topics, but if you want some clarification, feel free to ask. Anything pa? How about from the online? Meron pa silang chinap? Any questions from online or clarifications? Okay, if there's none, thank you. When is your exam? Monday then? Okay. Okay. Bye everyone from the online.
Bye, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you.